Welcome back to The Explainer. I am so pumped you're joining me today because, wow, we have a truly fascinating subject on deck. We're going to take some incredibly dense, complex cardiology concepts and translate them into a really clear, accessible diagnostic journey. Today, we're exploring the electrical grid of the human heart, and more specifically, what happens when that grid misfires. We'll be looking at everything from those harmless, everyday palpitations you might have felt, all the way up to invisible genetic anomalies that hide within a seemingly perfect heart.
Think about this for a second. Have you ever just been sitting there, maybe reading a book or drinking your morning coffee, and suddenly you feel your heart give this weird thump? Or maybe it feels like it completely skipped a beat. It's a very visceral and honestly sometimes kind of a startling physical experience. Well, that sensation, that's an electrical event. And when doctors look at an electrocardiogram or an ECG, they aren't just looking at random squiggly lines on a page. No, that ECG is a literal fingerprint of the heart's electrical map. It allows us to trace that exact thump right back to its source.
All right, here is our roadmap for today's risk spectrum. We are covering 1. The common skipped beat. 2. Decoding the Bigemini pattern. 3. The slow tachycardia paradox. 4. ARVC and structural disease. And finally, number 5, Brugada's hidden electrical threat. Let's dive right in.
Section 1. The common skipped beat. Let's start right at the very beginning of our risk spectrum with a phenomenon almost everyone experiences at some point.
So that sudden thump in your chest, that's most often what's called a premature ventricular contraction, or a PVC. By definition, this is a single ventricular beat that just fires off a little earlier than the next anticipated normal heartbeat. It's often due to something called enhanced automaticity, which is basically when a rogue cluster of cells just decides to fire on its own. Now, these can be completely benign. Sometimes they're just triggered by simple sympathetic stimulation like, too much caffeine, or maybe you're super stressed out. But they can also stem from more serious underlying issues like myocardial ischemia, which is a lack of blood flow to the heart, or electrolyte imbalances like hypokalemia, meaning low potassium. Now, when we escalate just slightly up the spectrum, we encounter NSVT, or non-sustained ventricular tachycardia. This happens when you have 3 or more of those ventricular beats in a row, but they terminate spontaneously within 30 seconds. If your heart is structurally normal, this is still often considered a totally benign finding. However, if the heart is structurally diseased, say it's scarred from a prior heart attack, well, finding NSVT on a monitor requires very careful evaluation because it can be a harbinger of much more sustained, dangerous rhythms down the line. So the crucial point here is, how do doctors actually tell the difference between a harmless PVC and a dangerous one just by looking at an ECG? It all comes down to the exact morphology or shape of the wave. If the PVC originates in healthy, normal heart muscle, the ECG will typically show smooth, uninterrupted contours and nice sharp deflections. The electrical signal is traveling cleanly. But if that signal is struggling through a diseased substrate, like a patch of scar tissue from an old infarction, the ECG trace is going to look completely different. It'll be jagged with broad notching and slurred deflections. The shape literally tells the story of the tissue it's traveling through. And this is where things get really sci-fi. Specialists can actually use advanced 3D catheter ablation mapping, sitting right alongside corresponding ECG tracings, to literally hunt down the specific origin of an ectopic beat. It's basically a highly advanced GPS for rogue electrical signals within the 3-dimensional space of the heart. For instance, they can track PVCs that originate from a very common location called the left ventricular outflow tract. It's absolutely incredible technology.
Section 2. Decoding the Bigemini pattern. Let's see how this builds when those premature beats stop being isolated events and start stringing together. Enter ventricular bigeminy. Bigeminy is a very specific cardiac rhythm where every single normal heartbeat is immediately followed by a premature ventricular contraction. It creates this relentless alternating cycle: normal, premature, normal, premature. It's this sort of organized chaos where the rogue signals have actually locked into a rigid 1-to-1 ratio with the heart's natural pacemaker. Now, what's really fascinating here is the physical paradox that Bigemini creates. It's known as the pseudo-bradycardia effect. Because a PVC happens prematurely, the heart simply hasn't had enough time to fully fill up with blood. Therefore, when the ventricle contracts, it might not actually generate a strong enough pulse wave to reach your extremities. So if you were to take a patient's pulse at the wrist, you might only feel the normal beats. That yields an erroneously low heart rate. It feels dangerously slow to the touch, even though the heart is actually electrically firing quite rapidly. Section 3. The slow tachycardia paradox.
Let's continue moving up our spectrum of risk to a condition that looks absolutely terrifying on a monitor, but is actually yet another physiological contradiction. We are talking about accelerated idioventricular rhythm, or AIVR. Similar to the dangerous ventricular tachycardia, AIVR consists of 3 or more wide complex ventricular beats driven by automaticity. It frequently emerges when the normal sinus rhythm slows down, like during sinus bradycardia, or, really notably, it pops up transiently during reperfusion therapy, which is when a blocked artery is opened back up during a heart attack. Now, the magic number here is 100. 100 is the absolute critical threshold. AIVR happens strictly at a rate that is slower than 100 beats per minute. That single metric is what separates this generally benign rhythm from true, hemodynamically dangerous ventricular tachycardia, which races much, much faster. Because of this, AIVR is often colloquially referred to with a wonderful medical oxymoron, slow ventricular tachycardia. It looks like a lethal rhythm on the screen because the complexes are wide and totally abnormal. But it's slow. Usually it doesn't even require treatment at all. It's merely a sign of the ventricular muscle cells taking over the pacing and is often described as a sign of the heart tissue just waking up as blood flow is restored. Section 4. ARVC and structural disease. Okay, we're crossing a major threshold in our explainer now. We are leaving the realm of common, benign extra beats and moving into the much graver territory of genetic conditions associated with sudden cardiac death. Our first stop here is arrhythmogenic right ventricular cardiomyopathy, or ARVC. This is a severe genetic disorder. What happens here is that over time, the healthy, robust muscle of the heart, primarily in the right ventricle, is literally replaced by a mix of fat and scar tissue. This is due to inherited mutations in the genes that encode desmosomal proteins, which are basically the literal glue that holds cardiac cells together. As that muscle turns into a fibrofatty scar, it becomes an absolute breeding ground for lethal electrical short circuits. So, how do doctors spot this structural decay before tragedy strikes? Well, they hunt for ARVC's unique ECG fingerprint. In over 85% of patients, the resting ECG will show abnormalities. We look for T-wave inversions in the right precordial leads, V1 through V3. We see a widened QRS complex because the electrical signal gets delayed as it trudges through all that fat and scar tissue. But the true red flag, the most unique marker, is something called an epsilon wave, which is a distinct little notch right at the end of the QRS complex. Furthermore, if these patients go into ventricular tachycardia, it typically shows a left bundle branch block morphology, which points straight back to an origin in that diseased right ventricle. Section 5. Brugada's hidden electrical threat. Finally, let's explore a condition that represents the ultimate diagnostic challenge in cardiology, a lethal threat hiding in what appears to be a flawlessly perfect heart. This is Brugada syndrome, and the truly terrifying clinical reality of Brugada is that if you take an ultrasound of the heart, an echocardiogram, or even an advanced cardiac MRI, the heart muscle looks completely 100% normal. There's no scar, there's no fat replacement. It is a purely electrical genetic flaw occurring way down at the microscopic level of the ion channels. It often strikes young, otherwise perfectly healthy individuals, frequently triggering sudden cardiac arrest right in the middle of the night during sleep. Because the physical heart looks fine, the Brugada ECG fingerprint is literally everything. Doctors are hunting for a very specific, infamous pattern, a greater than 0.2 millivolts coved ST segment elevation, followed by a negative T wave, again in leads V1 to V3. But here is the truly treacherous part. This signature can actually wax and wane over time. A patient's ECG might look completely normal on a Tuesday, but abnormal on a Friday. Often it requires specific triggers, like a high fever, or the administration of specific sodium channel blocking drugs in a controlled electrophysiology lab just to unmask that hidden lethal pattern. So if we put these two genetic culprits side by side, we see a really stark contrast. ARVC is driven by mutations in desmosomal proteins, resulting in the physical destruction of the heart muscle, that fibrofatty replacement, and it's marked by epsilon waves on the ECG. On the other hand, Brugada syndrome is most commonly driven by mutations in sodium channels, specifically the SCN5A gene. It leaves the physical structure of the heart completely untouched, choosing instead to sabotage the electrical software from within, announcing itself only through that elusive COVID ST elevation. Conclusion: the delicate electrical balance. We really have traversed the entire spectrum today in this explainer. We started with the incredibly common, usually harmless, premature skipped beat. We looked at how those beats pattern together in bigeminy, and we deciphered the slow tachycardia paradox of AIVR. And finally, we waded into the deep waters of complex genetic mutations, seeing how diseases like ARVC alter the physical fabric of the heart, while Brugada syndrome alters its invisible electrical code. I want to leave you with one final thought to chew on. We possess incredible technology today: 3D mapping, high-definition MRI, deep genetic sequencing. And yet, when a single microscopic mutated ion channel has the absolute power to stop a structurally perfect heart in the middle of a peaceful sleep, how much do we truly understand about the delicate, intricate microscopic machinery that is continuously, silently keeping you and me alive at this very second? It's a profound reminder of the fragile, beautiful complexity of the human heart. Thank you so much for joining me on this explainer. Keep learning, keep questioning, and I will catch you in the next one.